Condition 032 Loud and disruptive behavior of a 6-year-old boy. Candidate information and tasks. You are seeing a 6-year-old boy, Jonathan, for the first time with his mother, who complains how active he is. He is in his 2nd year at school, and his teacher has commented that he is disruptive and loud in class. Your tasks are to take a focused history from the mother to determine the possible causes for the child's presentation. Indicate to the mother your probable diagnosis and a brief plan of management. The performance guidelines for Condition 032 can be found on page 161. Condition 032 Loud and disruptive behavior of a 6-year-old boy. Aims of station to ensure that the candidate considers all other possibilities as to why Jonathan is behaving as he is, before concluding that he most likely has attention deficit hyperactivity disorder, ADHD. The candidate will therefore be assessed on ability to ask pertinent questions that confidently exclude other important diagnoses. The examiner will have instructed the parent as follows: you are the mother of Jonathan, aged 6 years, and are concerned about how active he is. Both teachers he has had in the first 2 years at school have commented on how disruptive he is in class. The candidate is required to take a concise history from you to try to determine the possible causes for Jonathan's behavior. Listed below are suggested answers that you should provide in response to questions from the candidate. At 6 minutes, the examiner will indicate to you to ask the candidate what is the problem and how should Jonathan be managed. Freeze of response. Questions are grouped based on how the candidate may question you. Hyperactivity and other associated symptoms. Jonathan has always been very active from the time he walked, 13 months. Even as an infant he was a restless, irritable baby who was difficult to feed. His sleeping pattern since birth has been very bizarre with frequent waking. He is impulsive and often acts without thinking what the consequences might be. He is easily frustrated and rarely plays at any particular activity for any length of time. His teacher complains he never sits still and tends to wander around the classroom, which at times is disruptive to the rest of the class. School progress. His reading and learning are behind the level of the other children in the class. He constantly talks loudly in class. He tends to interrupt frequently and has great difficulty taking turns. He has trouble keeping friends, as he is so boisterous. His preschool teacher commented on similar behavior. Home situation. He is the first in the family. He has a 4.5-year-old sister who already is reading, almost to the level that Jonathan has achieved. He lives in a caring family and you have tried just about anything that anyone has suggested to help him. The description given by the teachers is exactly as he is at home as well. He cannot concentrate on tasks for any length of time. He tends to disrupt his younger sister's play. He demands attention from you frequently, not being able to take no for an answer which you are finding exhausting. You consider your home situation to be very stable with both parents active in supporting each other and rearing the children. There are no parental interpersonal problems. Family history. His father is a plumber who struggled at school, left school as early as he could to take up his apprenticeship and who found it difficult to study at technical college, TAFE. Father is described by his own parents as being very similar to Jonathan at Jonathan's age. Father even now tends to leave tasks unfinished around the home. This is not a problem at work where he is supervised. There is no family history of intellectual disabilities or deafness. Mother was previously a secretary for a builder's supply firm. Pregnancy, you had a normal pregnancy. Jonathan's birth weight was 3,600 grams at term after normal labor, good APGAR scores, only mild and transient jaundice in the neonatal period. You noticed very active movements even in utero compared to when you were pregnant with his sister. Jonathan thrived and gained weight well. Development was normal except slow in speech development compared to his younger sister. Past medical history, physically well. No serious illnesses, in particular no history of meningitis, encephalitis. No history of head injury, although he appears uncoordinated and constantly seems to run into things. You have had his hearing and vision tested and were assured both were normal. Give this information only if asked. When indicated by the examiner, you should ask, what do you think is causing this, and what can we do about it? Expectations of candidate performance. This scenario is designed firstly to assess the candidate's ability to explore the reasons a child may present with hyperactivity. While it has been written to suggest ADHD, the assessment is essentially based on whether the candidate approaches the problem in a logical manner, exploring all other possibilities for the behavior. It is not at all critical that the correct diagnosis is made, but rather that the child's history is fully explored to exclude physical or congenital lesions. Behavior secondary to neonatal problems. Subsequent medical or physical illnesses including significant head injury. Reaction to unfavorable home circumstances or child rearing and family environment. Difficulties in the child's adaptation to school. A visual or auditory problem. Importantly, the candidate should question as to similar behavior in other family members. See note on father's history, in outlining briefly the probable diagnosis and plan of management. The candidate should give a logical explanation as to the possible causes for Jonathan's presentation, having excluded organic pathology, and indicate that ADHD is a strong possibility. The diagnosis of ADHD is not essential to pass, provided history has been satisfactory. Suggest a neurodevelopmental assessment be performed with an experienced psychologist if possible. If hearing and vision have not been inquired about, suggest having hearing and vision assessed, can then be told this has been done and is normal. Briefly outline the management of ADHD by behavioral modification with or without stimulant medication. Indicate willingness to review and monitor progress in a supportive manner. Obtaining a logical and focused history to exclude various possible causes for Jonathan's behavior. Showing empathy with the parent's frustration. Having a clear approach to the management plan. Critical error, coming to a premature conclusion of ADHD and recommending stimulant medication, without having explored the history for other causes. This presentation of childhood hyperactivity is common in both pediatric and general practice, and skill is required to sort out the myriad of causes for the behavior exhibited. This is done by a careful history exploring the child's past history, current developmental status, and family and school situation. Monitoring progress over several consultations may be required to give a positive diagnosis of ADHD. The great majority of children presenting in this manner have major family dynamics problems, and the scenario could easily have been modified to indicate this. However, the current scenario is designed to indicate that a diagnosis of ADHD is by exclusion of all the other causes for this symptom, and that stimulant medication is not the immediate treatment in this situation. a tendency for which has developed in the general community and is often the expectation of family members who have spoken with neighbors or read the lay press. The doctor is often under great pressure to prescribe these medications at first visit, and this should be resisted. There are no specific tests available that make a diagnosis of ADHD. Diagnosis is made from the pattern of behavior, which can be confirmed by psychometric testing. While behavioral modification is recommended, parents have often already arranged this prior to the consultation, and also have often tried a variety of exclusion diets that in some cases may be helpful, but overall are not. Parents should be supported to try exclusion diets if they are keen to institute them, but the practitioner should monitor progress and make a critical appraisal as to the success or otherwise of this treatment and support the parent accordingly.